Hello, I'm Dr. Lane Peterson, the author of the Expanded Dialectical Behavior Therapy Skills Training Manual, DBT Skills Training in Integrated Dual Disorder Treatment Settings, and Dialectical Behavior Therapy, a Contemporary Guide for Practitioners. Welcome to this one-hour training on creating safety, distress tolerance, and relapse prevention plans. In this training, we'll start by identifying who can benefit from these plans, and we'll see that the answer is a lot of different clients. Then we'll get into some of the essential features of a successful plan. And of course, throughout the training, I'll be talking about tips and ideas and skills and behaviors that can really be used to make these plans very, very successful for our clients. Now, it's fair to say I operate from a DBT perspective, so sometimes I use DBT language throughout a training like this. But these plans and the skills and behaviors that you put in these plans and clients put in these plans can be used no matter what theoretical orientation you operate from. So I think you'll find what we talk about to be extremely helpful. Now, to begin with, I think that anybody who has a safety issue, especially suicidal issue, but a safety issue of any kind, self-injury, self-injurious behavior, too, needs a safety plan. I can't tell you how many therapists I've met who do a nice job with assessment and a nice job talking about safety behaviors, okay, and they get it on a conceptual level, but they don't actually drill down and get a written plan together for the client and with the client. And the problem with that is, a lot of times we can remember what's helpful to do when we're not in crisis, but then when the crisis happens or when the urges spike, everything thought-wise goes out the window and people are just kind of wandering in the wilderness then, so to speak. They can't remember what their safety behaviors are. And that's where the written plan really comes in. When the chips are down, it tethers the person to, okay, this is what I need to be doing right now. This is what's going to be effective for me to be doing right now to manage this urge and to stay safe, okay? Now, in addition to people with safety issues, these plans can be used for all types of different urges and behaviors attached to those urges. You could use them with people with eating disorders, with people with substance use disorders and those behaviors, people who have any kind of addictive behaviors. And of course, these plans can even be used with lower level problem behaviors like overeating and overspending too. Now, certainly we have expertise for working with one set of disorders versus another, and I want to recognize that. And at the same time, no matter what the behaviors are, whether they're suicidal or whether it's overspending, there's a common thread that runs through them all, and that thread is you're working with people who have these intense urges that they're struggling to manage, okay? So it is all about managing urges and having effective replacement behaviors. So I sometimes say urges are urges are urges, and we're teaching people how to deal with that. And of course, the point of this training is how to get that down onto paper so that you can actually execute the plan. Now, as I mentioned, all clients with safety issues need to have a safety plan. To me, that's a non-negotiable, and I think that makes a lot of sense. But in terms of identifying what types of plans and how you're going to target them, it all has to do with careful assessment. So everyone is assessed for safety, needs to be assessed for safety. And of course, we're assessing for other types of problem behaviors too. The assessment will guide the planning. Once you know what the particular problem behaviors are, then you can start fashioning a plan around it, okay? And the plan needs to meet the standards of your profession. You want it to be thorough and complete and understandable to the client. But then importantly, there needs to be follow through with the plan. I can't tell you how many times I've seen a situation where therapists and clients come up with a really great plan, they get it down on paper, but then the plan disappears into a client folder or into the chart, or nowadays it gets scanned into the electronic record. In other words, it just kind of disappears, okay? And of course, if it's not there and people don't have it pulled up on a regular basis, they're not going to practice it on a regular basis either. And then of course, do make sure that you document all of this from assessment to planning to follow through. The rule of thumb is if you didn't document, it didn't happen. So you want to be careful about that. Now, I'm going to get further into educating and orienting in a moment, but it's quite important that clients know that you expect that they actually practice what's on the plan between sessions. Okay, that you actually practice it, that they have to do this. Oftentimes put it this way, to not follow through and practice what's on the plan is a lot like paying to go to a personal trainer and deciding that you just don't need to exercise in between sessions. And of course, if you didn't exercise between sessions, you're not likely to meet your goals of the training. So it's essential. And of course, we especially want people to practice it even on those days where urges are low or it's not, a risky situation. It's not a problem situation. I like to say that practice doesn't make perfect, but practice makes us prepared. And I have different metaphors for this I might use with a client. If you had to hit a grand slam in a big ball game, I hope you've done batting practice, or if you get pushed into the deep end in life, so to speak, hopefully you've splashed around in water some. So let's get some competencies with the skills and behaviors that go onto these plans. I like to call these plans living documents. Number one, because we're always reviewing them, revising them, and adding to them. I always want people to think about diversifying. One pitfall that can sometimes happen is people get a good enough plan or a brief plan together, and then they don't do anything to build on it. In fact, I'll start out in a little bit with a very simple safety plan, but as we go through treatment, I want that plan to become more and more rich and complex as the client becomes more and more skillful, so always growing from it. And then, of course, for people with suicidal issues, I refer to it as a living document because sometimes it literally keeps people alive. I can't tell you how many times I've had people who come in and they're not really sure about their safety. They have this sense of feeling unsafe, they're uncertain, but when we drill down and create a written safety plan, suddenly they go from this unsure, nebulous spot to looking at the plan saying, okay, I can do this. I can stay safe, which is a wonderful transformation to see. Now, more on educating and orienting. By the way, educating and orienting is just a really great therapy concept to keep in mind with everything that you might do with clients. As a general rule, the more that people know about what we're doing and why we're doing it, the more likely they are to actually participate and collaborate and to do this with you. And this is really the point, is that we're doing this together within the context of our therapy alliance, okay? So I say sometimes work a little harder to make it easy, or just kind of slow down. Don't be in such a rush. Talk about what these plans are and why we have it. Now, the lowest common denominator of buy-in, in my mind, is this. Nobody likes struggling with intense urges. Nobody likes getting into behaviors that complicate their lives or struggle with behaviors that are the very reasons that they're in therapy in the first place. Everybody wants to feel better. People want to be more successful. And that's really what these plans, help people to do, is to be more successful. Now, there's another element to this that I think is really important, and it has to do with monitoring, okay? Now, there's magic that happens when people are monitoring their behaviors in one way or another. Of course, what's popular these days is for people to wear a Fitbit. And I oftentimes ask people, when you put on your Fitbit and you have to choose between taking the stairs, okay, or taking the escalator or elevator, what do? Knowing that you've got this Fitbit, knowing that you have this thing that's cueing a plan, so to speak, and people say, take the stairs. I say, choice between taking the real direct route or, assuming you have time, walking a little further, taking the scenic route. They say, scenic route. Okay, same thing with the safety plan here. Same thing as with the Fitbit. When you have this plan that you're monitoring, then what you're doing is increasing this responsibility and accountability, for doing it. And that, of course, is quite helpful for clients. So we're thinking about buy-in, we're thinking about really getting clients attached to this idea and committed to following through on it. And while you're kind of setting up this education and orientation, it's also a good time to talk about your safety expectations. Now, safety expectations or agreements are essentially setting up different contingencies for the client to follow. Now, contingencies is a big word. It sounds complicated, but a contingency simply means setting up an if-then relationship that encourages people to be more skillful and discourages people from getting into unskillful behaviors. Okay, so here are a couple quick examples. Going to the airport is really an exercise in contingency management. When you understand the rules that you need to follow to go through security and you follow them, you go through smoothly. If you decide, that you're not going to follow the rules, you're going to put a water bottle in your backpack, okay, your carry-on, then you're going to have problems, okay? And of course, if you don't know the rules at all, so you don't know what to follow or not follow, well, there are going to be problems too. A lot of the issues that come up in therapy have to do with therapists who really don't set down expectations or agreements about how to handle certain situations, or they don't set up contingencies, these if-then relationships. If you follow the security rules, then you get through easily. If you don't follow the security rules, then you get special attention from the TSA, right? So therapists oftentimes don't set up these effective contingencies, or they don't follow through with them consistently, which essentially then teaches their clients that, okay, we come up with an agreement, but don't expect me to follow through. And of course, not following through on an agreement or contingency is disaster for therapy. And you know what? I use this analogy oftentimes with audiences. I say, there is a contingency or law that we have that if you speed, then you'll get a speeding ticket. But then I say, how many of you speed anyway? And I'll see the vast majority of people raise their hands. And I say, well, why do you speed? You know that if you speed, then you get a ticket. And people go, well, you don't get a ticket. Okay? And I go, this is an example of not following through with an agreement, expectation, or contingency. Okay? Your behavior doesn't improve, You don't drive more safely because you don't expect the consequence to happen in this case, right? I say, how about if you notice that the police have set up a speed trap on the way to work? Maybe, on this section of road, this 1 mile section, there's a speed trap there. Do you speed? And people go, oh no, I don't speed through there. Well, why not? Well, I get a ticket. Okay, well, that's just a case of more effective contingency management, and it does adjust your behavior, doesn't it? And I go further. I say, I've been in countries where they have traffic cameras, every so often and unpredictably. And what I find is that people will follow the speed limits because they know that otherwise, their picture is going to be taken and their license plate's picture is going to be taken and a ticket's going to show up in the mail, okay? So the contingency management and the follow-through in particular, again, adjusts their behavior. So I've got on this sheet here my common safety expectations or contingencies that I set up for people like that. Everyone's going to be assessed for safety, and you need to cooperate with safety assessments, or I'd have to send you to the hospital, be assessed by someone else. No one wants that deal if they know that I'm going to follow through. So I have 100% cooperation with assessments. Tells them what a safety commitment is. Tells them that, if you don't have a clear safety commitment with your suicidal urges and behaviors, then you'll be sent to the hospital. In that case, it will happen only by ambulance or police in terms of the transport there, and so on and so forth, including that all of what we do in terms of assessment and safety planning happens in our time that's allotted. Now, if you let people go overtime to do further assessment or safety planning, then what you teach them is that that's the best way to get more of your time and availability, and that just doesn't work for you, and it doesn't work for clients in getting them to be more skillful either. Now, quick note, this sheet, every other sheet that I refer to in this training will be available for you to download and copy and use freely, and I encourage people to do that. I also encourage people to, if they have an idea about how to adapt or change a handout to make it more relevant to their setting or more useful to them and their clients, I always encourage people to do that. So feel free to do that with my documents too. Okay, where to start? Now, this is a question I get all the time from therapists. I've got this client, he or she's come in, it's our first session, And I haven't, in the case of DBT, I haven't done skills training yet, or just if it's another type of therapy, I haven't had a chance to teach the client anything new yet. How do I actually create a safety plan? And I say, here's the good news. If this person has come in, and even if the person's been suicidal for 10 years or 20 years, the person's come in, he or she's alive, that means he or she has a lot of safety behaviors. That person has just not labeled those behaviors yet, and they probably only use them haphazardly, and we want to label those behaviors, and we want to get them down into an initial safety plan, so that they can go from haphazard use to predictable, consistent use. Okay, so everybody has safety behaviors. Everyone who deals with this urge or that urge for eating disorder, substance use behaviors, other types of behaviors, everyone who deals with urges has times when they successfully manage that and do something better or more skillful than the target or problem behavior. So again, I like to look at what have people already done, what are people already doing that's successful, and that's enormously empowering for clients to have them build from this area of strength, rather than just kind of going to the deficit and going like, oh my gosh, it's session 1 and what are we going to do? You don't have anything yet. Nope, you have a lot. There's a lot that's going for you. Let's start there, okay? So, as you go through, of course, you are going to be teaching people new skills and new behaviors, and that's why we make the plans more and more complex and rich as we go through, okay? And that's why we treat these plans as living documents, but you can start simple. Now, this here is an example of a safety contracting plan, one pager, pretty straightforward. Now, because I'm DBT oriented, I've got DBT skills I will use written on here. If you're not in a DBT setting, simply say these are the different skillful behaviors that I'll use, or these are the behaviors, or these are the skills, and just change the language accordingly. By the way, same thing with the title of these different plans. Go ahead and change the language accordingly. I could have just simply called this a safety plan without saying safety contracting plan. If you want to create a plan for something other than safety, then label what it is, relapse prevention plan, abstinence plan, sobriety plan, whatever you want to name it, go ahead and change it up if you like. Again, a lot of the common elements of these plans transcend whatever it is that you're working on. You just need to do a little adjustment and adaptation. Now, a quick note here. Doing an organized safety plan is different from this concept of a no-harm contract, even though, don't get confused, it does say contract there, but it's different from what we traditionally think of as a no-harm contract. Now, this is a no-harm contract. It is a simple piece of paper that says, I promise I will not harm or kill myself, signed, Lane Peterson. It's a simple piece of paper that's used in a very transactional way, oftentimes without any benefit of an established therapy alliance, without a further context of therapy, and without a specific plan that the person is actually going to follow in order to honor the contract. And oftentimes those no harm contracts have been done, again, in just a very matter-of-fact, cover your behind, kind of way, so they don't really mean anything. They don't mean anything at all for most people. And as such, being meaningless, they don't really help you in terms of your risk or liability, and they don't tend to be very beneficial to clients either. Now, what we're talking about here and in this hour is actually establishing a plan that someone's going to follow. It's got actual skills and behaviors to do. But even more importantly, it happens within the context of the therapy alliance or the therapy relationship. There's more to it than this quick transactional sign this, okay, thanks, I'm going to tuck this away somewhere, okay? And in fact, when I talk about having a safety commitment with a client, I'm talking about they're going to use whatever plan we've established, but it's also a safety commitment that, again, is done and documented within the context of the work that we're doing together. So it's really a big difference, okay? Now, again, I said this is a pretty simple one. It's not too overwhelming. You can do this session 1. It's got some places to write down safety skills or behaviors, and that sort of thing. So literally I'm going to say to someone, well, your urges are really high with suicide today, and obviously that's been a struggle for you. That's why you're coming to see me. What is it that you found to be helpful, to stay safe when those urges go up? What's worked for you in the past? And people say all kinds of different things, okay? Hey, I think it works when I'm around people. I find that if I'm around people, it's easier to stay safe, or I get around people in order to stay safe. What a wonderful skill. I might say, how do you do that? Well, I've got a neighbor down the hallway in my apartment building. I go and I hang out with him or her, or I get out of my apartment and I go down and hang out in the coffee shop on the ground floor. Or I walk to a park nearby and I sit on a bench and I'm just around people, and that's helpful. So you start, getting some specifics about it and then getting it down on the plan. Go to Lisa's apartment down the hall, Get out of my apartment and walk to the park. Go to the coffee shop. Whatever it might be, being specific about it. By the way, if you're walking somewhere, that's an additional skill, just getting some exercise, doing some self-care. We know from studies how walking can be hugely impactful in terms of decreasing depression. Just obviously just changing the environment when your urges are high can be really creating a factor of safety. What else is it that you do? Well, I read the Bible or whatever the religious text is, and that's helpful. Or I pray, or I call my sponsor, or I call a crisis line, or I put on a movie. I just try to distract myself. I'm really into comedies or dramas or, action movies, whatever it might be. Be real specific about it, and take those extra steps to question how the person actually kind of goes from idea to actualizing the skill or the behavior. And what you find is it doesn't take that much time to actually start to fill up this page with all kinds of options. And what an empowering thing for people who are struggling with urges of one type or another to discover, wait a second, there are times I am successful and I really do have options for dealing with this, okay? I'm not just flying blind. I've got stuff I can do. And then toward the bottom of this plan, there are all kinds of places for people to write in who their personal supports are, professional and of course personal. Now I'm a little bit old-fashioned here. I actually have people write down the phone numbers for their people. And I know nowadays most of us, we have these smartphones here. All of our contacts are in them. To me, it makes no difference. Sometimes joke around, I'm from the land of 10,000 lakes. Eventually your phone might fall into one. There goes your contacts, right? Or, not too long ago, my phone just broke. It just froze randomly. Hardware in it went out, and I lost all of my contacts. And of course, for a lot of us, that's a crisis in and of itself. So imagine suicidal, and then that crisis happens, and you don't have your contact numbers, and it could push anyone over their edge, right, with losing their phone or their contacts. So, write it down actually. And sometimes I even have people write down the availability of their different people. Okay, so if I walk down the hall to hang out with my neighbor Lisa, when is she around? Oh, she doesn't get home from work until 8 at night. Okay, so I know that, if it's before 8 at night, I need to work some of my other safety behaviors when she's not available. Kind of as an example. So you talk it through, and you work it and you mold it, and that's really what gets people kind of connected to this idea of, okay, I need to get this into action. And then down here it says, one goes to the client, one goes to the file. I always like to keep a copy of the safety plan on file. Not only is that documenting that I did it along with the client, but also, there have been situations where a client, for whatever reason, has lost the safety plan, and then we can take it from the file and get it back into action. Now, here's something that's really nice I haven't mentioned about having a written plan. Again, we're just starting with a simple one here. I've seen situations where therapists don't have the written plan, and at least from time to time, the client will come in and say, okay, my suicidal urges are up, or my urges to binge and purge are up, or my urges to do this or that are up. And if you don't have a written plan that you've established, what I've seen happen is therapists and clients, it's like they start from zero over and over and over. Here we are again for the first time. And that's just a tremendous inefficiency in terms of your session time, and it's not very effective for the client. And of course, if you and the client have to recreate what they're going to do every time that it pops up, you can bet 100% that they're not practicing in an in-between session. So when I have something written down and clients come in and they say my urges for whatever are back up today, I don't need to just start from zero. I can say, let's take out the plan and look, and oftentimes we can get the safety or get the crisis plan happening really rapidly, and that's efficient and effective. Okay. Now, as the client goes through treatment, I might make the plan a little bit more complex. Now, this one's not exceedingly complex. In fact, I've used this right out of the gates with clients too. This one, you see, the title's a little different. It just says Crisis Safety Plan. It could just say Crisis Plan or Safety Plan. Same point I made earlier. You don't necessarily get hung up on what the plan is called, or call it something different if you like. Here the person writes down their name, obviously on the top, who it belongs to. Makes sense. And then specifically whatever the crisis behavior might be. Might be overdosing, it might be cutting or some other self-injury, burning, it might be binge eating, it might be using alcohol or drugs, it might be going to the casino and gambling, it might be overeating, overspending. What is it that the person does that's not skillful when their urges are up and when crisis is really popping? That's what we're targeting here and being specific with that. Then we've got warning signs and triggers. I'm going to talk more about this when we get to the next plan that's a bit more in depth. But just in a nutshell now, I think about warning signs as being those flashing red lights. Here comes danger. Trouble's coming. Okay? Sometimes it starts so simple as one light flashing. I've stopped eating. Here comes trouble. Or the single light of I have a small amount of hopelessness. You have that light go. Or I have a thought. The world would be better off without me, and it flashes. Or someone's environment starts, becoming more disorganized and unclean, unkept, that sort of thing, and it flashes. Now, the more that you recognize these warning signs of different types and see all of these different flashings that might happen, the more that tells you, okay, we're really getting into a dangerous spot with our urges and behaviors. The time for action is now. Here's an important tip or idea that I always share with clients. A lot of times we get into this sense of complacency that it's not bad enough yet. Only one warning sign flashed, or only a couple of them flashed. It's not bad enough yet. Or my depression, is at a 5 out of 10, but I'm not going to take much action until maybe it's at a 6 or a 7. Or you kind of get the idea that people wait to respond. The problem is, the more complacent we are and the more we wait to respond to whatever the warning signs or flashes are, the harder it's going to be successful once we finally do kick our skills or behaviors in. So at the very first indication of trouble, very first warning sign that you identify that you experience, you want to be working the skills plan now. So I'll revisit the idea of warning signs in a bit. And of course, triggers are, what are those things that set off the crisis behavior? Those things that set off acting on whatever the urge might be it safety or around another behavior. Now, on this particular plan, I've got it broken down into particular skills modules that are common in DBT. Of course, mindfulness skills, distress tolerance skills, emotion regulation skills, and interpersonal effectiveness skills, as well as a place to write down other skills. And there is a page 2 also to this plan. This one is a 2-pager here, but we'll go back to page 1 here. Now, if I'm starting with this 2-pager out of the gates, this is also a great time for me to start providing some education around some of these modules or overarching skill sets that we teach in DBT. Okay, everything is a teachable moment. Everything is a time to start talking skills and or behaviors. So mindfulness skills, just looking at that gives me and the client a time to just really briefly talk about what it means to be mindful and how we can use that. So I might say, in a nutshell, mindfulness is about taking hold of your mental processes and directing your thoughts and your attention to where you want your thoughts and attention to be. Okay? So for example, you could be very, connected to or attentive to your urge or your distress and just be marinating in that. Okay? And that might not be productive for you in a sense, and this is a technicality, that really wouldn't be mindfulness if you're just kind of stuck in it and it's ineffective. You're not attending to it in a mindful way, you're attending to it in a stuck, ineffective way. But let's not go too far down the rabbit hole. I want people to just kind of get the general ideas at this point, and in skills training we can get deeper into the nuance of what this is versus that and the next thing. But I might make that point, that you could be really attentive to your urges or your pain or your problems in this way where you're marinating in it and ruminating about it and catastrophizing about it, and it's causing you more problems. Or you could mindfully distract and put your attention on a positive experience, or reading a book or watching a movie or doing a puzzle. In other words, direct your attention to a place where it's going to be much more helpful and effective for you. So, what are you going to be mindful of? You can start getting some ideas down there. Now, as we teach mindfulness later on, like I said, we wouldn't go too far down this rabbit hole, but I do want to make this point. When we teach mindfulness later on, we're going to teach that mindfulness is actually about this process about how we attend. It's not just what we attend to, but how we attend to what we attend to. Okay, so for example, when the person has gotten more skills training in mindfulness, we might teach them that, sometimes the solution is just this kind of mindful acceptance and tolerance of the urge, the pain, the discomfort, without this idea that you need to change it. But this mindful acceptance of it means that it is a true welcoming and acceptance, okay? Meaning that there's not any kind of deal or negotiation attached to it. See, sometimes clients think acceptance means that, well, if I attend to it and I accept it, then whatever it is that I don't like is supposed to go away, okay? And that's not really true acceptance. True acceptance is welcoming it however it is, without any expectation that it needs to do anything for you in exchange. There's no deal or negotiation. So, later on down the line, we might talk about, those deeper and somewhat more abstract concepts around mindfulness. But I said we wouldn't get too far down this rabbit hole, so we're going to pull ourselves back out of it. But certainly, we can look at, our interpersonal skills here. This is a great time to introduce this idea that when we're struggling, when we're having a tough time, it's important to use our assertiveness to reach out for help. If you have a substance use disorder, you might call up your sponsor. Or you might get to a meeting and use your interpersonal skills to connect with other people who can understand your struggle and give you some support around working your abstinence. Other ways to use interpersonal skills that you could introduce just right out of the gates without having to teach a whole lot is this idea that sometimes focusing on other people in a relationship-oriented way can be really helpful when we're in crisis. Get a break from whatever it is that we're struggling with and be there for other people, and of course doing that in a mindful way. So on the second page here, we're going to have our list of people to call for support or reach out to. And that would very much pertain to the interpersonal skills. Emotion regulation skills, again, out of the gates, it's pretty easy to introduce these ideas that the more you take care of yourself, work your self-care skills, the better you're going to be able to manage yourself and manage these urges and get into healthy behaviors rather than falling into the target or problem or crisis behavior, right? Okay. Now, in chemical dependency treatment, they have an acronym. It's not a DBT acronym, but it's their acronym. It's called HALT, right? Hungry, angry, lonely, tired. Now, for some people, obviously, those are warning signs that they might get into a substance use behavior. Those are the flashing lights, those words captured in the HALT acronym, okay? But also, it speaks to what the person needs to do. I need to eat. I need to do something to manage my anger, agitation. I need to do something to manage my loneliness, get into the interpersonal skills there. I need to get some rest, okay? And of course, in terms of self-care, it's very rare that I meet people who can benefit from some kind of self-care skills, okay? So we're working on balanced eating, getting some movement, some balanced exercise, sleep routine, sleep hygiene. All of these things can be found very easily online, and of course in the different skills manuals, mine included. But the more we get the self-care happening, the better. And then in addition to that, building positive experience. This is DBT language. Building positive experience, that's pretty self-evident. Building mastery, that means doing those things that help you feel more competent and in control, which makes a difference when otherwise you might feel out of control. And of course, we talk a lot in DBT about what we might call O2E, opposite to emotion, which means acting opposite to those behaviors that certain emotions pull us into, okay? So, if a warning sign for, let's say, a crisis behavior like self-injury, if a warning sign was seeing an increase in depressive level, well, depression pulls us into isolating. Depression pulls us into inactivity. The opposite to emotion would be reaching out to people, again, interpersonal skills, reaching out to people and getting more active, okay? And we can see where those skills themselves would speak to, what's going on in terms of, contributing to the difficulties. And then, of course, we have distress tolerance skills. These are all the healthy replacement skills that we teach people. So getting into healthy distractions, watching movies, doing puzzles, contributing to others, doing relaxation, using positive imagery or guided imagery, as examples. And the great thing that I always try to tell people about this too, remember I'm always harping over and over in a nice way about why we need to practice these behaviors and practice our plans. The nice thing about these behaviors is they tend to be pretty pleasurable or enjoyable to do anyway. I'm not saying they're always easy to initiate for clients, and oftentimes it's very difficult for clients to initiate and practice these behaviors, but when they do, they're just so beneficial and so nice to do anyway, and sometimes that can get some buy-in with that. Now, on the second page, I have a place for people to list their medications and their dosages and medical alerts, and that would be, for example, if they needed to go to the hospital or crisis center, they would have that information. And then, of course, people to call for support: therapist, prescriber, case manager, family, friends, others. What I love to see is when people need additional paper. And certainly people can expand upon any of these areas, and it's wonderful when they do so. And then, again, original client, copy to chart, so that you have this in your chart, and so on and so forth. So this one, a little bit more complex. And then we move to, this last one that I'm going to share. And this one is one that I like to move clients to when they're ready for it. You don't need to wait a long time, but kind of once they've gotten acclimated to therapy and you're really starting to kind of expand what you're doing, that sort of thing, then I might move to this type of crisis plan. Now, one thing that I like about this plan is it has a little bit of this education and orientation right at the top of the plan, Fill out this plan and continue to add to it. Treat it as a living document, continuously review, practice, and update it. Paraphrasing this. Make several copies, know where to find it, really, really important. I don't think I've mentioned this, but it has certainly happened where I've had a client come in crisis, and I say, take out your treatment plan. And they're kind of rummaging through their folder or through their things, and they can't find it. And then, of course, I say, that's the first issue. It's going to be really difficult to do if you can't find the plan. So make several copies, know where it is. Give copies to people in your support system. Discuss the use of that plan proactively. And again, practice. Practice is what makes you prepared to be effective. And one of my favorite things about this particular plan is this area here where it says, my reasons for managing crisis effectively and/or staying safe. In my mind, what this does is it starts to elicit protective factors or those why reasons for people to follow the plan and either stay safe or if the plan is around other types of crisis or problem behaviors, why they want to use their skills or effective behaviors instead. Okay. Now about whys, the motivating factors. Viktor Frankl once famously said, if you can identify a why, you can do almost any how. And I think when he said that, that comes from an enormous place of authenticity. But also, again, this motivates people. The why might be, I want to stay in my own apartment, or I don't want to be hospitalized again, or I want to be stable enough to have a pet, or I want to get out of this treatment program so I can go to college, or I want to prove someone in my family wrong. I oftentimes talk about this client I had many years ago where her reason for staying safe was to be there for her cat. She felt like her cat, who she loved, was not a cat that anyone else would care for or love. And so she felt not only her tremendous affection for her pet, but also a responsibility. And so, for her, that was a real linchpin of why she followed her plan. And for me, I'm not concerned about what people's whys are so long as they're important to that person. So getting your reasons for managing crisis or staying safe down here, your priorities, your goals, your values, or referencing the people who matter to you, really orients the person toward getting in and doing this. Then another thing I really like about this particular one is getting into the strengths and the resources. What is it that you have going for you? Okay, so life might be hard, but maybe you've got supportive friends or someone who's supportive in your family, or I hope you find your therapist to be supportive. Sadly, that doesn't always happen, but it should be a high percentage of the time anyway. What else do you have going for you in terms of strengths or resources? Maybe you're resilient, or maybe you have transportation. Resiliency is a strength, transportation is a resource. Maybe you identify what's going well for you. Maybe everything isn't doom or gloom. You actually have some things that are going your way, and it's helpful to remind yourself of that. So this is an area, along with this too, that kind of taps into strengths. Now we're back to this idea of warning signs. These are the signals, as I mentioned earlier, that you might be heading toward crisis or even being unsafe. And this cues people to look to their history for clues. I'm going to switch to the second page here. This is where we get more specific. What's going on with your feelings, your thoughts, your behaviors, sensations, in other words, what's happening in your body, what's going on in your environment. So for example, I'm going to kind of talk about some things that a person might put down in these particular areas. A person might say, I know that I'm heading for crisis, or I know that I'm heading to an unsafe spot where I might use self-injury, or I know that I'm heading to an unsafe spot where I might act on suicide when my depression climbs. And in particular, I see my depression go from under 5 out of 10 to, a 5 or 6 or higher out of 10, depending on where that individual would see that tipping point starting to come. The person might further say, I notice feelings of hopelessness coming in, starting with just that first low level of hopelessness and then having that build and build and build. And so eventually the person is identifying increasingly strong feelings of depression and increasingly strong feelings of hopelessness. So those could be feelings that might come in for a particular person around safety. What thoughts are you starting to see? I start thinking that I don't matter. I start thinking that people wouldn't miss me. I start thinking that the world would be better off without me. I start ruminating on these thoughts, just sitting there and chewing on them over and over and over and over and over. It's hard for me to think about other things. I become preoccupied with those thoughts, or the thinking becomes obsessive around it. However the client might characterize the thinking. What's going on with the behaviors? Okay, Maybe the person says, I stopped doing my dishes, I stopped doing laundry, I stopped emptying the cat box, I stopped picking up and organizing around my house, I stopped cleaning, okay? And in terms of my other behaviors, I start to isolate, I start missing appointments. I stop lifting the shades in my house in the morning, you know? I become more inactive, I stay in bed. So identifying behaviors that are warning signs. How about sensations? What is a person experiencing physically? And maybe the person says, I feel a mix of fatigue, low energy, and at other times agitation in my body. Sometimes going back and forth, whatever the person is noticing with that. And environment. Now, some of what you might see in the environment, you know, might be reflective of some of the behaviors too, like the person's talking about, you know, stopping doing all of these activities of daily living around the house, taking care of the chores in particular. Of course, that's behavioral, and that's going to be reflective in what they see, you know, in their environment, you know. So you start to see those cues there. Now, as I mentioned earlier, it's like all of these, you know, warning signs flashing. And the key is when you start seeing those first warning signs and those lower intensity warning signs, you kick your plan into action. You don't get complacent, but you get, you know, right on top of it right now. And then we've got our key triggers here. Now, I like to say that, you know, the warning signs is kind of like piling the dry timber, you know, in the fireplace or in the fire pit, you know. That's all of those things that are, you know, making the chance of a dangerous crisis behavior happening, or safety, suicidal or self-injurious behavior happening, you know, making the probability of that ripe, you know, and high. And then the trigger, I say, is kind of putting a match to all that timber. It's the thing that sets it off and inflames it all. And, you know, for many people, they know what their triggers are, okay? It might be an abandonment for one person. It might be getting written up at work or getting a bad grade for another person, you know, loss of a relationship, you know, which could be a real thing, where an abandonment could be real or a perceived abandonment, you know, or it might be something else. So what are the things that set off the crisis or being unsafe for a particular person? And then, of course, are there any barriers that could get in the way of using your skills? You know, for some people, it can just be willfulness. I know what would be the effective thing to do, and I just want to choose not to do it. You know, and of course, that's a therapeutic issue to work through with the person, but it's helpful for them to identify that as a barrier so that you're able to do that. You know, sometimes the barriers are just really you know, practical. I can't find my plan, which again speaks to why we have multiple copies and we want clients to know where their plan is, you know, at all times, you know. Or someone might have another type of barrier that they see, you know, real or perceived. You know, my perceived lack of support is a barrier. I think if people are not backing me up, then why should I do it? Whatever it is, you know, we want to address that. And then we've got this skill here called bridge burning, okay? Bridge burning means removing the means of acting on your harmful urges, okay? So let's say the person who's filling this out, and we're giving this example here that sounds very much like someone heading down a pathway toward being unsafe, maybe acting on a suicidal urge. Let's say that person's suicidal plan was to overdose on medications, washing down that overdose with a bunch of vodka. Well, we could just burn the bridge, right? When the person is in a safe place, when they're not in crisis, they might choose to take their stockpile of meds down to the pharmacy, turn them over for the pharmacist to destroy, and to get the alcohol out of their home. So that even if things were getting really tough here, going way far down this road, they've removed the means to act. Now let's talk about other behaviors too. If you had someone where their plan was around not binge eating, burning the bridge would be getting all of that binge eating food out of the house, for example. Okay. For someone with substance use behaviors, burning the bridge might be getting alcohol out of the house, or for people who use drugs, getting all their drug paraphernalia out, throwing that all away, blocking their dealer's phone number, changing their phone number, all bridge burning behaviors. For people who self-injure, it could be getting rid of their razor blades or scalpels or that sort of thing. Now, many people who I've worked with who self-injure, sometimes they don't want to give up that very last razor blade. And in that case, I say, hey, how about you freeze it in a plastic glass of water? Of course, plastic so it doesn't break in the freezer, but freeze it in a plastic glass of water. You can't use that razor blade until it melts out of there. And of course, what that does, even though the bridge isn't completely burned, it creates that inaccessibility to it that takes so long that it gives them a chance for their urges to go down and to practice other skillful behaviors in the meantime. So if you can't burn the bridge completely, get as many stoppers in there as you can, right? So someone might have a certain amount of medication, not a stockpile, but a certain amount of medication that they need for the month. It's what's prescribed to them. Now, sometimes I've had psychiatrists prescribe in smaller doses, but let's say they have a month's worth of medication. Well, rather than having that on your nightstand next to your bed where you could be in despair and could act on it, how about you put that medication in a lockbox in a high up place in your kitchen in a more public area where you'd have to go through several steps to take an overdose rather than just doing it impulsively like you might next to your bed. So burning the bridges, creating barriers. And then we see getting into these specific areas again, specific self-care skills we can use, distress tolerance skills to use. Then we get into personal support system, listing again those people in your life, non-professionals. And then we have a place here for professional support system. Again, I like people to write down their numbers, medications and doses, hospital of choice, and then the commitment, and again, original client copy to your plan. Now, this is just kind of a sampling of plans, and in my manuals I've got other variations of this. Health maintenance plans would be another example, and I've seen going on Google, you can Google safety plan or crisis plan, those keywords, and you can find lots of other public domain plans that are really nice. One that I can think of in this moment that I really like is it goes through, it says, these are all the things that are helpful for me when I'm in crisis. These are all the things that are not helpful for me when I'm in crisis. And of course, it orients the person toward what to do and what to avoid. Now, I've already mentioned many of these categories of behaviors. Of course, these really come from DBT tradition. There are a lot of great skills manuals out there where you can learn more about these skills. Of course, these skills all come from other evidence-based therapies. These skills aren't really original to DBT, but they're out there far and wide in CBT and behavioral therapies especially. So again, you can go to the internet, Google, and put in crisis management skills or behaviors or safety behaviors and get long lists of these sorts of things. And of course, getting into a lot of these skillful, helpful behaviors are really a topic of another training. But that said, I've also included a couple worksheets here that I oftentimes use to supplement the safety plan, really targeting particular skills. This one here is for distress tolerance skills or crisis skills. And I've got place 1, 2, 3, 4, 5, 6, 7 places on this, 7 days a week. Coincidence? Probably not. But a place where they can put down whatever their crisis tolerance skill is, distress tolerance skill is, every single day of the week, checking in on their distress level or urge level generally before and after practicing the skill. I love this. It's just a really straightforward worksheet, very understandable for people. Of course, I just really briefly paraphrase, it's got the full instructions on the top there. But it gets people not only practicing the safety plan, but targeting specific skills on their safety plan each day of the week and noting the connection between using the skill and feeling better or managing the urge, which, once they notice that connection, it really ratifies why they do this. And of course, this one here, another sampling, is about building positive experience. And here I was explicit, I put each day of the week. What their build positive experience is going to be. Of course, the more positive experiences you have, the better you feel, the lower your urges are, etc., etc., etc. Working on what works in life. So what you're going to do for a build positive experience, where and when, the scheduling is really key. Really quick point here. There was a study many years ago where one group of people agreed to do a task, committed to it. The other group of people agreed to do a task, committed to doing it, but they were particular about where and when, and they accomplished the task 80% more of the time. So small point, but if you get nothing else out of this hour, that's a big one. Scheduling is key to get clients to do a lot of different things and to get us to do it too. And again, you have your distress and urge level before and after. When they see the improvement that happens with that, again, it ratifies that this is helpful to do. So, great sampling of some skills, some distress tolerance plans, crisis plans, safety plans. I hope you find this helpful. Again, you can download and use these resources, put them to use. And I want to thank you very much for spending this time with me, and I hope you find this to be useful for your clients. Have a great day.